Ben Roth is going to talk when to include L5-S1. Ben, if you're ready, you may start. Welcome.
Thank you very much. All right, let me get the hold on slideshow. Let me see if now it's better. Do you see it now?
Yes.
Yeah, it's much better.
Wonderful. All right. So that's the topic, is when to fuse L5-S1. So when do we ask this question? Clearly, we're not going to ask the question when there is a clear instability at L5-S1. But there is a dilemma when L5-S1 does not have an independent indication for fusion, but the high risk may exist for future degeneration due to adjacent segment disease, especially when a fusion at higher levels ends at L4-5. You could call it floating L5-S1 segment, although some people call the L4-5 fusion itself, when it's isolated, a floating fusion. ASD or adjacent segment disease can occur only radiographically or progress to become clinically significant. So I will start first with a discussion of what's adjacent segment disease. Long-term randomized control studies, including for 10 years or longer, and it's something that I discussed and presented, I found out a few years ago, shows that fusion accelerates degenerative changes at the adjacent level compared to natural history. The rate of adjacent segment disease after different spinal interventions was similar. We may suspect that adjacent segment disease also reflects natural history of spinal degenerative disease in many cases, or is maybe even a non-specific response to surgical intervention. Clinical adjacent segment disease is less common, and requirement of repeat surgery is actually rare. The annual incidence of ASD requiring surgery was about 1% per year for 10 years after primary surgery. Interesting is those of us who work in trauma centers have seen, and one of my colleagues, Tim Moore, in my previous job in Cleveland, actually published, that ASD was very rare after fusion for trauma in young patients without existing degenerative disease. So maybe it does increase that risk, but if you start with healthy spine, except for a fracture, in the course of reasonable follow-up, you don't see that. So there is no single universally accepted and validated outcome instrument to diagnose or quantify this ASD. We know that ASD can be made worse. So, sorry, I just jumped. Sorry. Yeah, ASD can be made worse. We know that multi-level fusion and facet degeneration are associated with increased incidence of ASD and need for reoperation. So pre-existing degeneration, again, that's the reverse of healthy people who only get fusion for trauma, don't get ASD, but pre-existing degeneration is a risk factor for developing of ASD. In certain conditions, it is significantly more common. So if patients already have spondylolisthesis, and maybe neighboring levels started to degenerate, maybe is at a risk for spondylolisthesis, then ASD does progress faster. And we know that isolated floating fusion ending at L4-5 may actually be associated with more ASD. So the degeneration at L5-S1 or subsequent degeneration is associated with long fusion arthrodesis terminating at L5 in patients with adult scoliosis. And a study from 2018, relatively recent, demonstrates that the prevalence of subsequent L5-S1 disc degeneration after long fusion arthrodesis terminating at L5 in patients with adult scoliosis was close to 60%. 36 of 67 patients. So clearly, it's a very high rate, and higher in those patients where there was pre-existing degeneration. In a different study by Takegami et al. In 23, so really even more recent, they demonstrated that the number of fusion levels was a significant candidate factor for clinical L5-S1 ASD. So that's kind of interesting. You see on the right is an illustration of really a very long segment fusion, and you see that L5-S1 is not fused there. So it kind of illustrates the concept. So there are some additional clinical considerations here, and we know that there was in posterior lateral fusion a high risk of L5-S1 disc height reduction and foraminal stenosis in patients with multiple level fusion. And there was also a large study from the Johns Hopkins group. So Bidon et al., Zygourakis is in the same list. And they followed 511 patients who underwent instrumented arthrodesis for lumbar degenerative disease over a 23-year-old period at one institution. That's not very common in North America because of very high rates of loss of follow-up here. And the follow-up was average of almost 40 months after the index lumbar arthrodesis. And indeed, patients who had floating lumbar fusions were significantly more likely to develop ASD over time than those who had lumbosacral fusions incorporating the S1 spinal segment, but were less likely to experience postoperative radicular symptoms. So it's interesting that there was kind of a price to pay. For some reason, including L5-S1 right off the bat, increased the incidence of postoperative radicular symptoms. I'm not sure why. I could speculate, maybe just you add more surgery and you could cause net more complications. We also need to remember that SI joint pathology may develop after L5-S1 fusion. It's not the last level. And it could be treated with SI joint fusion procedures. That's a very recent paper. But sometimes you also have very poor bone in S1. And then you need to anchor, as many of our orthopedic colleagues, some of my neurosurgery colleagues do. If it's a very long construct, just anchor it to the pelvis directly. On the other hand, preserving the L5-S1 motion segment does not add to function. So it's okay to just add S1 right off the bat, and the patients apparently will not feel, according to a study by Daniels et al. From 2017, they probably will not feel a difference clinically. Now let's go to the short arthrodesis. We talked about the long arthrodesis. How about the short arthrodesis? If you just do L4-5 or L3-4, L4-5. In early studies, like Zileli et al. From 2003, things that influenced me earlier in my career, there appeared to be no need to routinely include the L5-S1 segment when performing a posterior lumbar fusions. They followed patients for average of 7.3 years, and we're talking about like 80s, 90s index surgery. And there was neither increased symptomatic disc degeneration nor symptoms necessitating the need for another procedure. A different study, an L4-5 floating fusion, ASD did occur in the patients, and the radiological ASD was more common in the cephalad segment and clinical more common in the L5-S1. And again, like in studies before, the pre-existing spinal stenosis appears to be the most influential risk factor in ASD incidence, unlike the cephalad segment. So it's interesting, right? You have different types of adjacent segment disease developing above the L4-5 and below the L4-5 fusion. So is it clinically important? What does it actually mean? Again, lots of studies that look at it from various directions. I think the most interesting one was a finding by Dish et al. That patients who underwent fusions in the segment L5-S1 showed lower risk for adjacent segment disease than patients with fusions at L4-5. Right? And bisegmental L4-S1 fusions also showed a similar trend with lower risk for ASD. And To me, what I think about it, my interpretation, is that L4-5 floating fusion had two segments that could degenerate, the one above and the one below. So uh, even in theory, it should result in more adjacent segment disease than fusions where only one segment, the one above, would degenerate. But there was no difference in the clinical results in that study. Again, this is a follow-up time of between 3 to 22 years with average time of 14 years. So it's not a large number of patients, but a very long follow-up. And again, no difference in clinical results. Um, I am still doing, and many of my colleagues still do, an L4-5 single segment fusion, and it's not an automatic indication for L5-S1 fusion. Does motion preserving surgery make a difference? A big meta-analysis by Don Elliott et al. Didn't show a statistically significant difference in that incidence. They did some weighted analysis, which I tried to understand it, but I apologize, I did not understand what they did there with the weighted analysis. They claim that there is some difference. It's very difficult to reach definitive conclusions, and there's a lot of conflicting reports in the literature, and mostly because fusion that is less rigid or motion preserving procedures that do stabilization without intent to fuse, but with preservation of motions, there are so many different approaches here that it's difficult to pull them all together into one. I don't think it's valid. I think each one of those approaches needs to accumulate prospectively enough patients with enough follow-up to have its own individual judgment. What about no instrumentation at all? Well, we know that no instrumentation at all may result in fusion at a lower rate than instrumented fusion. But if the fusion happens, then I think it would have logically the same outcome. We know that there is no difference in overall functional improvement, pain-related outcome scores, reoperations rates, or complications rates, amazingly, between patients who were treated with instrumented fusion and non-instrumented fusion. So the fusion rates are higher with instrumentation, but repeatedly. And I was reading this 20 years ago, and in 2022, a review by Hirasa et al. Demonstrates the same thing. So we still are facing the fact that fusion can happen and clinically may be equivalent whether you put instrumentation or not. Now, the problem is that it's not typically randomized. So if a surgeon believes that you don't need to do instrumentation, maybe the surgeon was right. So I don't think we can learn from this that we just shouldn't put instrumentation and just do uninstrumented fusion. Absolutely clearly, there are so many cases where the patient is unstable, fracture, deformities, gross instabilities, where it won't work without instrumentation. So I don't think it makes a difference whether you instrument or not for the purposes of adjacent segment disease. And we know that adjacent segment disease can develop after non-instrumented fusion, and also after laminectomy without fusion as natural progression of the disease. Finally, there is no fusion like no fusion at all. Even in the presence of spondylolisthesis, the indication for fusion remains controversial. And we all know those two famous articles that came in 2016, one next to the other, one from the American group that includes Ogogawala and Benzel and Volker Sonntag and others, just really across the board, the leaders of US spine surgery. But ultimately, it was a very small group of patients, and they demonstrated that you need to add lumbar spinal fusion to a laminectomy. Otherwise, there is even higher rate of reoperation. But using a different inclusion criteria, not selecting for patients with spondylolisthesis, but just pulling them all together, decompression surgery with fusion or decompression alone, that didn't make a difference. But again, you could say reasonably that these two studies did not compare the same population. That really to compare it properly, you needed to do what the American group did. But their group is relatively small and they had a very high rate of reoperation. So it's just something that I like to mention because we often are doing fusions with instrumentation for patients who may not need it and may do well without, and we need to be careful because if we don't do an instrumented fusion, although degeneration at adjacent levels can happen, but it will happen, according to all the articles I cited before, at a lower rate. So what are the take-home messages? Well, one, radiographic adjacent segment disease can occur at L5-S1 segment after fusion of segments above it. Clinically significant ASD can occur, but is less common. If the construct is long, clinical ASD appeared more likely. It may be advisable to add S1 and even pelvic attachment, or at least discuss the risk of further degeneration and further surgery with the patient. But I think it's quite safe. And according to some of the studies that we reviewed, it doesn't really harm the patient significantly to add S1. Again, maybe there is a higher risk of radiculopathy if you add the S1, but in the balance, I would say it's probably advisable. Probably it's advisable. Again, I don't think there is a clear consensus or it's entirely uncontroversial, but the prevalence of evidence is to add that. If the fused segment is short, and especially with a single level L4-5 fusion, adding L5-S1 should only be considered if there already is significant stenosis and degeneration or borderline instability. If the level is healthy, adjacent segment disease develops very slowly, and it's probably not essential. All right, that's it. And thank you very much. Questions?
Ben, thank you so much for this really beautiful presentation. So it's really a difficult topic to discuss also. So when you're stopping at L5, you have problems like, as you mentioned, you have 50% degeneration at the L5-S1 level. If you go to S1, again, you have some problems. And especially if you're doing adult degenerative scoliosis cases, commonly you have to go to S1, especially in the Russell type 1 cases, that's because the apex of the lumbar lordosis is at L5. So you have to do something, and I will say something different according to the literature. We have prepared some WFNS recommendation papers. Even in these papers, especially in thoracolumbar trauma, the literature says that fusion, and when they're comparing fusion and non-fusion surgery, they say that there are no difference. I'm talking about clinically.
Yeah.
If you fuse or if you don't fuse that part, clinically they're not, they don't have difference, but radiologically they have. And as you mentioned, all of the changes on the X-rays doesn't mean they may have symptoms. And another topic, as you have said, the peak roads, and let's say the semi-rigid systems, maybe a solution for that, but we can discuss about it.
Yeah. Yeah, absolutely. Thank you very much. And I think that this is exactly, I completely agree. The comparisons that are being made are not always very, very valid because they are not done prospectively, but they are done with surgeons having the freedom to decide how to treat patients. So we rarely see patients who are very grossly unstable and cannot stand up without stabilization, really not having stabilization surgery with instrumentation. We have typically we have patients who the surgeon decided that maybe they don't have to do surgery, or they don't have to put instrumentation, and then they are followed. And in many cases, looks like the surgeon was right. So it doesn't mean that from now on you should never put any instrumentation. It means that, well, maybe the judgment when left to the surgeon in those cases was reasonable. Zogagawala for many years, maybe more than 20 years, has been promoting the idea of surgical equipoise. So you would randomize patients in a study, but only among those where the panel of surgeons who helped in designing the study decided that there was an equipoise between the compared approaches. And then you compare it. Well, yes, then you can truly randomize them and they will not be lost to the study because something else was done or because the surgeon has a different judgment. But then you will only limit it to situations in which surgeons truly do not feel that there is a big difference between the approaches. So surgeons could be surprised, like they were surprised in the recent study that showed that laminoplasty it was superior, surprisingly superior to laminectomy with fusion and anterior approaches for multi-segment cervical stenosis. It was a surprise. You can find certain things, but other things will be limited. Things that are controversial about topics such as fusing an unstable patient, that some people would believe that it's just inappropriate. Like you will never be able to truly compare a study because there won't be any equipoise, and maybe there shouldn't be equipoise. So it's this research in spine is very complicated to do, obviously.
You're right, Ben. Thank you so much. And if you have time, please stay with us. So we know where we have to go to S1 or where we have to stop.